Hello and good afternoon, everyone. I am Nancy Baxter. I am the head of the Melbourne School of Population and Global Health, and I am very pleased today to be the MC for the online edition of the VCCC's Monday Lunch Live. First, I would like to acknowledge the traditional custodians of the land on which I am located, as well as the VCCC, and those are the lands of the Wurundjeri people. They've been custodians of these lands and waterways for thousands of years, and I pay respect to their elders, past, present, and emerging, and I extend that respect to other Indigenous Australians present online. The VCCC has some very interesting speakers coming up, so please register your interest via the website. They also have a learning page if you would like to review previous topics, and this is likely to be broadcast there on their YouTube channel, so may well be recorded for future viewing. If you have any questions for today's presenter, you can do this via the Zoom question and answer function. Please submit your questions through the presentation, and we will aim to answer your questions at the end of the session. I think we're going to have a lively discussion at the end of the session. I'm really looking forward to it. So our presenter today is Professor Christobel Saunders AO, who will be discussing the topic, getting the best value for our cancer patients. Professor Saunders is internationally recognized as one of Australia's most prominent research-oriented cancer surgeons. She has substantially contributed to many clinical aspects of breast cancer research, including clinical trials of new treatment, psychosocial, translational, and health services research, and is very active in several areas of surgical oncology cancer research, with a particular emphasis on breast cancer. In recognition of her sustained career excellence and innovation, Professor Saunders has been publicly acknowledged through numerous awards and honors. She has performed research for more than 30 years evaluating the efficacy and utility of therapy for early breast cancer, and in the past 5 years has published over 100 peer-reviewed journals, 6 editorials, 2 research reports, 2 book chapters, and 1 book. She sits on the boards of a number of cancer organizations, including the Australia-New Zealand Breast Cancer Trials Group, is president of the Breast Surgical Society of Australia and New Zealand. She's closely involved in strategic planning and management of cancer services in Western Australia, as author of the WA Health Cancer Services Framework, and as first associate director of the WA Cancer and Palliative Care Network. She's the inaugural chair of the State Health Service Provider PathWest Laboratory Medicine. I will hand this over to Dr. Saunders, and I'm really very much looking forward to your presentation today.
Thank you, Nancy, and thank you very much to the VCCC for inviting me. It's a delight to be here. What a shame I can't be over with you guys in person, but hopefully soon that will happen. So I'm going to share my screen now, and hopefully everybody can see this. And what I'm going to talk about today over the next 40 minutes or so is really the idea of getting the best value for our cancer patients. And I know at times you may think, goodness me, surely we're all doing our best for our cancer patients anyway, and we are, but we know that we can always do a little bit better. And what we're going to talk about today is quite a wide variety of things, looking at variability in outcomes and therefore why it matters for us to look at that. I actually want to explore with you a little bit more the value, the concept of value-based healthcare. We'll be discussing PROMs, what, when, how, where. PREMs, what the patient-reported experience measures tell us. I'm going to be going through a little bit about the project we've been doing here in WA in cancer to look at value-based healthcare and really how you optimise a value-based model for organising cancer care. And then finally, I'm going to touch on another project where we're looking at developing bundles of care for patients with early breast cancer. So with no more ado, I will launch in. But first, maybe some context. As I said at the beginning, you may think, goodness, why are we talking about getting better value in care? Well, if we first talk about cost, that's always the thing we need to think about first. And although clearly we have excellent healthcare, it does come at a price. And in fact, interestingly, of all the OECD countries, Australia is actually the 7th highest in terms of cost in spending per person. We actually spend around $6,600 per person for healthcare each year. And actually, that's in fact probably going up. If we look at where that health spending actually occurs, and the only time I'm going to mention COVID today is this does not include our COVID spending budget. This was up until then. You can see But really it's spread out quite evenly over funding our hospitals through the National Health Reform Agreement, funding Medicare benefit schedules, so private care and general practitioner care, and to a lesser extent funding the drugs that we use. And you can see that this is a significant amount of money, $60 billion a year at the moment, and ever growing, an endless black hole for which we pour money into health. But of course, we are achieving great outcomes for this. And if you look at what this investment in terms of money has brought to us over the last number of decades, our life expectancy is excellent, at least in non-Indigenous Australians. It's up to 84.4 years for women. Our disability adjusted life years, in other words, we are living not only longer, but better and weller as we get older. Less people smoking and less people drinking. But we still have some big health challenges. And those really revolve around the things that you know about well. The increasing numbers of people with chronic disease, the number of people with obesity and overweight that lead to much of that chronic disease. And of course, one of the biggest causes of that chronic disease is cancer, which even though we're doing well with curing cancers, the incidence of cancer inexorably continues to rise. And that's 22% rise since 1982. So I wanted to look at a little bit more in terms of globally about context. And when you look at care, you not only need to look at a country overall, but you need to look at the variability in care. Now, this first slide shows you actually not variability in outcomes, but variability in actually what we actually do for patients. These are 3 countries, obviously, outside Australia, and 3 conditions outside of cancer. But you can see huge variations in actually which patients are recommended for different treatments, depending on where they live, that postcode lottery, if you like. And I can assure you that, sadly, it probably is the same to an extent with cancer as well. If we actually want to look at the outcomes of care, a good one to choose is prostate cancer. And these slides show you some of the variability in outcomes of men diagnosed and treated for prostate cancer. And this is in Europe. Now, of course, that variability is going to very much depend on what outcome you pick. So if you pick the outcome of mortality, well, we do pretty well. The vast majority of men with prostate cancer survive at 5 years, and their prostate cancer doesn't come back, or at least doesn't bother them in terms of its recurrence. And it's very difficult, therefore, if you're going to compare between different institutions or different countries to see whether, if you pick mortality, to see a difference. But if you pick side effects and the outcomes that matter to patients, you can see that they vary widely. And this comes from an example of somewhere called the Martini Clinic, which is in Germany, in Hamburg, where they specifically focus on trying to deliver the very best care in prostate cancer. And when they looked at the outcomes they wanted to focus on, such as incontinence and erectile dysfunction, working very hard on these, they could significantly improve these outcomes over above Germany as a whole, or indeed other European countries. And of course, the other important thing to realise is that there's variability in the cost of achieving good outcomes. And if you look at that variation in cost, this is over a number of countries in the OECD, there's enormous variations over all diseases that we know. Now, this is the real problem that we have. We have variation in outcomes, we have variation in costs, and variation indeed in practice. And if this is the case for cancer, how can we try to bring things up to the very best standard that we can possibly deliver? Focusing back into the Australian context now, and cancer specifically, the cost of cancer to the Australian government is significant. Given that overall bucket of money that we saw of somewhere around 70 billion, cancer is a significant part of that. And indeed, between 2009 and 2013, it was estimated that we spent around $6.3 billion on cancer care in Australia. The highest cost of that, and Nancy, I know will be interested to hear this, as a colorectal surgeon, was bowel cancer. Second was my particular field of breast cancer, followed by lung and prostate cancer. So the big 4 cancers were really the most expensive. The other really interesting thing is if you tease out when that expense occurs, as you might expect, most of it is in the first year with diagnosis and initial treatment with surgery, chemotherapy, radiotherapy, etc. But the most expensive was actually the last year of life, and in fact, significantly, the last final month of life. So if we're thinking about cancer, which we know is the largest contributor to disease burden overall in Australia, and it's a leading cause of death, we need to think about these costs and what we can do about them. Probably the only answer that we have is a shift in the whole way that we're thinking. And that's what I want to spend the next half an hour or so of this talk to try and get you to change that shift in thinking. And we need to shift from thinking of pushing large volumes through, just doing large numbers of cases, getting the patients through, to actually shifting to an idea of looking at value. And what do I mean by value? Well, value-based healthcare is very much that equation described by Michael Porter from the Harvard Business School of the health outcomes that matter to patients, and the end of that sentence is what's very important, that matter to patients, over the cost of delivering those outcomes. If we know what they are, then we can start to achieve better value for patients. Value-based healthcare, however, it's very difficult to understand it if you just concentrate on one episode of care or one hospital or one intervention or one bit of the whole patient journey. What we really need to do is look at the patient, put them in the middle, and look at their whole cycle of care, all the way from prevention, diagnosis, treatment, supportive care to end-of-life care. And that's particularly important for any chronic disease. And unless you can improve the value at all of those points, which may include things such as pathology testing, radiology, as well as our traditional oncology care, you're not going to really improve value. But the single most powerful lever for reducing costs and improving symptoms is improving outcomes. If a patient doesn't experience lots of side effects, if a patient experiences a good outcome, they're cured of their cancer, then clearly that's going to be the best, not only for the patient, but for the whole system. I've put this slide in because I found this really interesting. This is from Gregory Katz's group in Paris, who are very interested in this. And what they found was when you actually start to make the sort of data that we're going to be talking about and collection data of outcomes transparent and published, and people can see what it is, it immediately starts to improve outcomes. So actually just knowing what our outcomes are and knowing what our practices are is a great way to immediately improve those outcomes for patients. A recent publication by the Deeble Institute, which has a particular interest in this country in value-based healthcare, suggested that the opinion leaders that they canvassed voiced the need for this real paradigm shift in healthcare, away from the current focus of cost cutting and activity-based funding, the things that we all struggle with day to day as clinicians, you know, how long the patient's staying in hospital, how much it's costing for that particular activity that we're doing in the hospital, really towards prioritizing and incentivizing the delivery of this kind of value-based healthcare. Changing the priority of us as healthcare deliverers, as well as for patients, towards a value-based model. So if you put the patient in the middle of this, this is the way it might look. And I've put up here an example of two patients with breast cancer, very similar, mother and daughter, but in fact their journeys, their treatment pathways and their outcomes may be very different. And we need to think of the patient in the middle, but also what value-based healthcare may mean for the provider, the payer, and the whole system. So we're talking about not just clinical outcomes, but the experience of care, the patient-reported outcomes, the variation in those outcomes, and the cost of care. So if we're going to look at outcomes, clearly we need to work out how we measure them. And what we can do then when we get those to act upon them to increase value. So it's really important in this value-based healthcare system that we not only improve outcomes not only measure outcomes, but we look at the cost of delivering those, and then how we can actually do better to achieve better quality care at a better value. Now, there are different ways that you can tackle this very big and difficult to look at beast. You can either do a sort of light touch or a real transformational thing, and each health service, each practitioner will need to think what they can do within their own practice. So by light touch, I mean you may think about your own particular very specific area of cancer patients that you're looking after. You can look at a very limited number of outcomes or process indicators. You could just look at the budget that you have control over. You can look at just some informal collaborations with others who pay that budget. Or right at the other end, you could look at a whole population. You could look at all of Victoria and cancer patients. You could get some really good outcome measures based on the priorities of the whole population. You could look at the entire budget from woe to go of delivering cancer care for Victoria or indeed for Australia. You could look at how we actually deliver those contracts and how we can change those. So really from the light touch to the transformational. And I'd suggest that for each group, it's going to be a little bit different, and each of us will be able to do a different bit of this pathway. What we found when we started to look at how we applied this in cancer in WA is that there were some real enablers, some things that made it easier to think about this practically. So the first way that you can really practically get about this is having good, organised, what are called integrated practice units. And I know that you already largely have that for cancer in Victoria. So that is really our multidisciplinary pathways, getting everybody together, including community care, the general practitioner, and end-of-life care, into organised integrated practice units. Then you need to define what you're going to measure and how much it costs. And we'll talk a little bit more about that later. One thing that I'll talk about at the end, which I think is probably more appropriate to some of our private care here, is how we can bundle payments together for a care cycle. But interestingly, there's also a lot of work going on about how we may be able to do this in the public sector, for example, bundling care around radiation oncology in this country. We also know that many patients are not just treated at one centre. They often move between different places, and that may be because they have, for example, their diagnostic tests at one place, perhaps in the private sector, and then move into the public sector to have care, or perhaps they have their surgery at one hospital and their radiation oncology at another. So it's very important to integrate facilities and to expand across the whole geography. Many of our patients in WA live very widely apart from the metropolitan area, so we've had to work on that. And the key thing I put at the bottom that I'll come back to again and again is the information technology system platform that you use to enable this. The other thing that we very quickly realised is that this isn't something you can do just as one person. You need really a whole load of collaborations to do this. I'm a surgeon and I'm a researcher. So when I started on this journey, I did it with a research lens on, but very much realised quickly that we needed to get a whole load of healthcare providers and clinicians as champions so they could understand this and bring it forward. But importantly, we also needed the patients and their families to come on board and see this was important. Really importantly, we needed to get our policymakers, if you like, those within the government, within the health departments, and indeed within hospital administrations, the payers, to come on board, as well as to an extent industry. So if we could invest in innovation that matters to patients to really make more efficient care. And you need to have this group around you to see how best you can really deliver value-based healthcare. So I said it was important to work out what you're going to measure. And this is really the first thing you need to think about if you're going to do this. Without measuring things, without knowing what our outcomes are, we can never get better. So what on earth do we measure? Well, we're very good at measuring clinical outcomes, aren't we? We're very good at measuring survival, recurrence, we're not bad at. We're good at looking at x-rays to see whether there's been response to treatment, at blood tests. So those are the clinical outcomes, and it's reasonably easy to define a set of those for your particular cancer that you want to measure, as well as some process outcomes, perhaps, length of stay, what kind of operation the patient has, what the side effects of their surgery or their radiotherapy or the chemotherapy will be. But I do want to stress to you the importance of adding in the patient-reported measures as well. And that's both PROMs, patient-reported outcome measures, as well as PREMs, patient-reported experience measures. And we'll go over both of those in a moment, but putting all of this together is what's vital for this journey. Now, you may say, goodness me, measuring patient-reported outcome measures, that sounds all very well and good in practice, but it's just asking patients how they are, and we do that anyway in their outpatient visit. But this can be a very powerful tool, in fact. And this interesting study published a couple of years ago in JAMA was looking at survival in a group of lung cancer patients who were reporting their patient-reported outcome measures. And we saw that patients, this was being reported electronically, and patients who were reporting their outcomes actually survived better than patients who didn't. Whether this was because they were being presenting earlier, they were being picked up when they had side effects or progression of treatment, and therefore change of treatment was possible, is difficult to know. But we know if you listen to what the patient has to say, you can actually not just make them feel better, but improve their survival. This was a very interesting graph from this paper, because it showed that even for patients who weren't actually very computer literate, if they still reported their own outcomes, you could actually improve hard outcomes. And in this case, this hard outcome was an unplanned emergency room visit and hospital admission. So in listening to the patient, recording it and flagging what those outcomes are really important. And we all know that, because if you ask a patient how well they are, what we report, what the doctor reports, is often not quite the same as what the patient reports. So if you ask a patient, you'll probably get a better view of what their actual symptoms and their problems are. So this was patient reporting versus physician reporting of orthopnea, and you can see that patients were much more likely to report this significantly than were their physicians. So what about this thing called PREMs? Now, again, in Victoria, you guys are pretty good at doing this. I know that you do annual surveys of how patients feel their journey. And I know there's been a lot of criticism over reporting PREMs. You know, if you ask patients how their journey was, they'll usually complain that it was the car parking, which was the worst thing. But I think asking patients about their journey and their experience along the way can give us really important feedback on the perception of the healthcare service or the healthcare delivery. And in fact, a recent Deloitte report indicated that hospitals with better patient-reported experiences actually do better financially. So if we can get the patient experience right, we can actually perhaps make our cancer care delivery cheaper as well. Now, rolling back to some Australian work in value-based healthcare, I'm happy to say that this is really beginning to take off, not just around the world, but here in Australia. And there's some good examples that I'm going to show you of not just in cancer, but in a whole load of areas across health, where Australian healthcare providers, clinicians and patient groups are beginning to get very interested in this. And they're getting interested in it, as I said, because we know we have a growing and aging population, increasing rates of chronic disease, we have terrible health inequality across the population, cost is rising, there's this unwarranted variation in care and health outcomes, and because patients are beginning to expect better care. So this is just a few examples. In your own state in Victoria, the public dental health services are doing a fabulous job of looking at introducing value-based healthcare. And they've already begun to show that they can actually get better outcomes for their public patients by measuring outcomes that matter to patients, looking at them, reporting them, discussing them, and acting on them. And they've already shown a significant increase in, for example, preventative interventions, as well as getting rid of some of the low value care, the things that weren't really improving patient outcomes. And so it looks like this may also be a cheaper model of care. This has taken quite a time to set in and to be able to set up, but is beginning to show results. In New South Wales, there's the New South Wales Health Department are very interested in the idea of patient-reported measures to form a real way of evaluating the care that we're delivering and to plan better care across many chronic diseases. So they're using it to monitor quality and refine service delivery, and trying to enable value-based healthcare to have real patient-centered responsive care that's both effective and efficient. Queensland have got a number of initiatives, and I liked this quote in the second paragraph from the Queensland Minister a couple of years ago of Health. It said the Queensland government were going to try and make a trip advisor for hospitals that would allow patients to compare public and private hospital outcomes across a range of specialty areas. And I'm going to try and want to move on to the project that we've been doing here in WA. For the last 2.5 years, we've been interested in value-based healthcare, and we couldn't unfortunately get the health department to really move on this. So we thought we'd do this as part of a research project, really the end of which is we'd like to see this taken into normal care. So we decided to do it in cancer because that was our area of expertise, and we decided to look at a multi-institutional program across 5 different cancers and across 5 different institutions to really see if we could properly measure outcomes, look at the variations in outcomes and act on those. Really importantly, we had to develop an informatics system that was able to capture clinical and PROMs data and any additional data that we thought was important. And we used for that, as I'll come on to in a moment, some of the International Consortium of Health Outcome Measures, the ICHOM data elements. We needed to integrate then this IT system into both the public platforms of IT as well as the private platforms within the private hospital we chose. And we need to work out how to feed this data back to clinicians and patients so we can actually look at how we can change our clinical intervention to improve outcomes and improve practices. As I say, we chose to use the ICHOM standard sets, and some of you, I'm sure many of you may be familiar with these. ICHOM is a group based out of the United States that have developed standard sets for outcome measures across a whole range of different areas of health. They've developed 5 in fact in cancer, across 4 cancers: colorectal, breast, lung and prostate cancer. So we decided to look at those cancers, but we also added on ovarian cancer. We've had to start at the beginning and develop, along with the national group, the MOST group, some outcome measures in ovarian cancer. Now, when you're developing these measures, it's not just sort of picking a few things that you might want to measure clinically and some PROMs. It's actually quite a detailed methodology, and I was very fortunate to be involved in the breast cancer data set, along with some people, in fact, from Melbourne, where we had a group of people from all around the world, including many patients, get together, multidisciplinary approach to work out what outcomes were most important to measure and at what time points, and then develop this standard set, which then gets refined. And we've actually used these standard sets, but then altered them a little to suit our local circumstances. And we've had to integrate this then into our rather complex IT system. And I know that in Victoria, you now have in much of Victorian hospitals an electronic health record, which should be able to make this process easier over time. So you integrate the measures that you want into the electronic health record. Within our project, we've kind of got about halfway through now after 2.5 years. So we started off engaging all that wide range of people that I talked about at the beginning, both the hospital-based and patient-based stakeholders. We established a way of collecting data, which is an open source tool that we're using, and we've managed to embed that now into both our public health system and our private data collection systems. So we've started being able to capture data on patients in these 5 cancers in both public and private hospitals. We're now working on how we can deliver that data back to both the patient and to the treating clinician, but also how we can analyze that data to look at variations in care. So the idea of this data is it's being able to be used both in the one-on-one consultation, but also when you're comparing care between different units, different hospital sites, or indeed different geographic areas around the world, to see where our variations in care are, and we're then setting up projects to actually improve those variations. So we've still got a little way to go, and it certainly took us longer than we thought, and it's been an interesting journey, but that IT side, I can't stress to you, is so important. As I say, we're across 5 different cancers at 5 different public and private hospitals. And really what we've been able to do is increase the capacity of our health system to do things like collect electronic PROMs and work out how those can get flagged at important times when an important result comes back to the individual clinician, but also how we can develop dashboards to compare those. And benchmark them importantly with people around the world. In early breast cancer, there's been a number of projects going on in, for example, Holland and across Europe, looking at very similar outcomes in early breast cancer, so we're able to compare them. And that's really this idea of value-based healthcare. Now, I've put this rather complex diagram up because I just wanted to, this is again from Gregory Katz in Paris, but this really does describe, if you're going to implement this system, the sort of things that you need to think about. So we probably did this. We thought about a few conditions, and in this case, a number of cancers. We got the team together that were going to implement this, in our case, the research team, as well as clinical champions in different hospitals, and ensured that all the hospitals were on board. We defined the processes, so we looked at the outcomes we wanted to collect, and we're doing some big projects looking both publicly and privately at the costs of delivering those outcomes. We developed the appropriate data platform. We looked at benchmarking it across other sites, both within WA and around the world. And now we're to the point where we need to start investing in improvement, both perhaps taking away care that is not so useful, but putting more care in where it will be useful to get better outcomes, and creating incentives for clinicians to be able to do this. The last thing we want is more work. You don't want to have to collect more data yourself. You want this to be done electronically, but to give you the power to improve your own care. And then finally, the idea of external collaborations and a learning community is something we'd love to see around this country. So going back to the patient, looking at the patient, we thought we'd ask the patient what was really important. So if you ask a patient to tell us what their issues in cancer care are, the problems that they define, they want an efficient diagnosis, they want joined up seamless care, they want support psychologically, they of course want the best outcomes they have, and they want to understand costs. Now I want to just tell you for a few minutes about some more work in this area that was done, and this was by a group called AllCan, which some of you may be familiar with. AllCan is a global group, mostly in Europe, in Canada and in Australia, who are a multi-stakeholder initiative. So we have both hospitals, we have industry, as well as patient groups who get together to really look at how efficient cancer care can be delivered. In this country, AllCan Australia is led by a steering committee, in fact from Melbourne, with John Saltberg and Richard Vines from Rare Cancer Australia chairing this. And what AllCan decided to do was have a survey around the world of patient experiences to see what was important to patients when it came to having the most effective and efficient healthcare. And they wanted to understand this across the whole continuum, so we could focus on ways that we could improve. So the survey was actually rolled out just over a year ago now, and it was run in a number of countries, including Australia. Nearly 4,000 current or former patients and a few caregivers answered the survey, and there were about 30 or 40 questions. And we came up with 4 key findings, and I think this is really important when we're thinking about how we deliver this value-based healthcare. These were the 4 areas that patients thought were important, and I'm going to go over these in a little bit of detail. So the first was a swift, accurate and appropriately delivered diagnosis. Now, of course, you say, of course, patients want to have that when they've got cancer. But interestingly, for patients diagnosed outside a screening program, a significant number, a third, had multiple diagnoses of something different than their eventual cancer diagnosis. And many found that they had to wait more than 6 months to have a true diagnosis of what was wrong with them in the end. That varied considerably across cancer type and was obviously much better for people going through screening programs. It's an area we need to work on. You're probably not surprised at hearing that what patients really felt they lacked was information, support, and the ability to undertake shared decision making. We think we're good at this, but in fact, this was exactly the same results in Australia as the rest of the world, that nearly half of patients didn't feel that they were sufficiently involved in deciding which treatment option was best for them. Many felt that they weren't supported enough. And interestingly, 35% felt that they weren't given enough information to tell whether their cancer was coming back. So there were big gaps in information and support. They also very much wanted to see multidisciplinary care as a reality. Many commented that when there were the existence of specialist cancer nurses or navigators, that vastly improved their patient journey. They wanted more information about things such as diet and exercise. And 69% needed psychological support, but 34%, a third of patients, said that it wasn't available to them. And finally, and this is something we often forget, the financial implications of cancer. Even in these health systems, and most of these studies were done in Europe, where there were care for everybody was available, still 51% of respondents paid for some or part of their care. And that was often in non-medical costs, such as travel and loss of employment, but it could be for medical costs as well. Right. We also noted that this was across the care continuum, so for patients with early disease right through to advanced disease, but worse for patients with advanced disease. So one way that we've decided to try to improve some of those issues is around looking at something called bundled care. And I thought I'd present very briefly to you another project we have embedded in our value-based healthcare project of how we can try to bundle care. We've decided to do this for patients with early breast cancer, and we're doing it in collaboration with Genesis Cancer Care. And if you think of yourself in the position of a patient diagnosed newly with cancer, often that treatment pathway is unclear. You don't know what side effects you're going to get and when they're going to arise. You don't know how you're going to manage all of those. You don't know who you have to go and see, when you should go and see a physio, etc. And the cost of all that is a huge concern. So the idea is to try to really look at the entire pathway of care, navigate it for the patient, and bundle it together so there is a known cost right up front at the beginning. So either a known or a no gap. And we know that that will improve the patient's journey, their psychological and physical trauma will be reduced. We started to do this, as I say, in breast cancer, and it's quite a complex thing to do. You start mapping out every bit of the journey and then putting a cost against it. And this is just one slide to show you some of this complexity. It actually gets quite a lot more complex than that. Because of course patients go down different pathways, so you have to navigate what they are and work out, if you're going to put a bundle together, how much that costs. But we're ready to start rolling this out, and we hope to show that for patients who have a bundle of care and have a navigator to take them through this journey, they'll have considerably better patient-reported experience and outcomes at the end of that. And this is in prostate cancer. This comes again from the group in Paris rather than our own group, as we've not started doing this in prostate cancer yet. But you can see that if you're measuring the costs of the different aspects of prostate cancer care, it's very complex. And although actually having an operation is the most complex cost, there are all sorts of other places that you might not necessarily think that you need to look at how you map these costs. So success for value-based healthcare is a complex thing, and I'm not sure that we've really got there yet. We're probably about halfway through our journey, and we hope to be able to roll this out within the next few years across WA, across a number of hospitals. But it is a complex area, but one that I think we're getting our teeth into. Some of the success factors that I'd like to say to you, that if you're going to think about this, you really need to think about. You need to think about what health outcomes measurement you do, and most importantly, how you get your data systems worked out so you can collect that data. It's very important to be able to define the entire care pathway for your patients, right from woe to go, from diagnosis all the way through to supportive or end-of-life care, and try and make sure that we do practice within integrated practice units, as if we know this makes outcomes better and it makes it much easier to do this. You need to try and work out the costs along that journey, and that's a difficult task to do, and you need help doing that. But I think most importantly, you need the clinical leadership. You need the people who are committed to doing this, and we need to change our behaviour to see that this is a good way of doing this. And finally, the most important, I think, is consumer engagement in this process, because if patients want this to happen, then hopefully eventually it will happen. This is just our implementation strategy that we've tried to think about. So clinical communication engagement strategies are so important. And our roadmap, these are just a few things we put into our roadmap to really try and make this work. We are just running through, perhaps just on the left side of this, I think the really important thing is picking a few demonstration projects to see if you can do this, and then seeing whether they can be scaled up with some strong leadership. You need to think about all these other things though, including risk management, clinical engagement, and clear and consistent communication. Otherwise, you're going to end up collecting data that you don't know what to do with, you don't know where it sits, and it doesn't really change care. So if you are interested in this area, we'd be very delighted for you to join a conference that we are co-organising in May next year. We're organising it in partnership with the Australian Hospital and Healthcare Association to really try to raise the awareness of value-based healthcare and the work being done in this area in Australia and New Zealand. It's aimed at us clinicians as well as health service managers, policymakers, academics, consumers and researchers. In the run-up to the Value-Based Health Conference next May is a workshop run by Dell Medical School from Austin, Texas, who have a particular interest in this area. It'll be a fantastic two-day introductory workshop before the conference. And it's going to be a very practical and a hybrid conference online as well as in person here in Perth. So I've just put this little promo up for the conference, and hopefully by next May our borders will be open and we'll be able to welcome you to come back here, and I think it'll be an interesting area. And this again is the website. So I'll finish there and say thank you, and thank you both to the funders of our research as well as all to my many collaborators both here in WA and in Melbourne and in Victoria as well as elsewhere around the country who've been involved in this work, and I'll open things up to questions. Thank you very much.
Thank you very much, Christobel, and I want to congratulate you. That's a huge amount of effort to get something like that off the ground, particularly in so many different cancer sites, not just focusing on a single site with respect to your measures and integrating outcome measures in the IT system. We have a great question in the chat, and I'm waiting for more to come in the question and answer, but this is from Catherine Bell, and it's from a consumer point of view. Upon diagnosis, there's virtually no information available to understand how to choose a provider. And this is an important element in terms of, for some cancers, determining what treatment you're going to have actually for prostate cancers. And then in the Australian system, in terms of how much the treatment is going to cost, say in the private, public sector, or one hospital versus the other, what might be the best way to address this?
I completely agree with you, Catherine. There isn't, is there? And I think that was why it was interesting that the Queensland Health Minister suggested trying to develop a TripAdvisor for different hospitals. It's not as easy as we think, though, because we know that obviously there's a lot of variations in care that are not necessarily due to the hospital or the provider. So they may look after sicker patients, so they might not have, their patients might not do as well because of that. I think the only way we're really going to get to the bottom of this is to systematically introduce this area of value-based healthcare. We know when a hospital or a system or a provider does go down this route and measures the outcomes that they are achieving, they automatically improve their outcomes. So, once you know what you're doing, you're going to do better. Whether we'll eventually get to the point where we will have this TripAdvisor, I'm not sure, but I think it behoves us both as a public system and as a private system to make sure that we measure what we do and we try and improve things to get the best we can. I don't think at the moment, Catherine, I can tell you more than that, sadly. I don't know whether anybody else, Nancy, do you have any other ideas on that?
I'm just becoming familiar with the Australian healthcare system, and there is a lot of opacity that I think understanding how we can better enable patients to navigate the system and to fully understand the costs. I think there definitely have been movements towards that, and I think more can be done. I really like your idea of the bundling. I think that does work for some disease sites, particularly where the care is does not vary very much, and that's going to be very useful to patients as well. Obviously, Christobel, you're very engaged with this, very passionate about this, have a lot of knowledge and information, and a lot of ability to get people together, convening power to get this done. What do you think for someone who's starting out on this journey? What were the key enablers for you? What were the things that you really look to bring together right at the beginning to start the journey in this? Because it's a mammoth task you've undertaken.
It is. Well, I think the first thing was that understanding that this idea of measuring outcomes was important, and that we could work out a way of doing it, and then becoming passionate about it. I've never met a doctor, a clinician, a nurse who doesn't want to get the best possible outcomes for their patients. We all do, but often we just simply don't know how we're doing. You do, however, need to get those on board who are going to actually enable us to be able to do that. So getting the hospitals on board, for example, the people who are running the hospitals, whether it's a public or a private hospital, so they see that when they're developing their new IT systems, that's an important part of what they do, and they can feed that information back to you. The VCCC are in a very good place, I think, to be able to do that, because they are bringing a number of systems together. There's some great electronic enabling in Victoria. But finally, I think the most important thing was getting the patient voice. If patients tell you that's what they want, that's a really powerful way of being able to change things.
I thought that the video that you showed was interesting and certainly compelling in terms of saying, when we have alternatives to care, particularly, then understanding what patients want is exceptionally important. In terms of this value-based care kind of journey, one of the things we do have to face are competing interests. So, you know, the prostate surgeon and the role of the prostate surgeon in terms of deciding what treatments to offer, deciding how treatments are described, etc. So how do you think that should be managed? How do you think we should deal with those types of things?
Yeah, that's a very good and interesting and difficult question, actually, Nancy. And I think it's one actually that, in fact, the world of prostate cancer in this country is tackling quite well, because they really are engaged now in trying to collect good outcomes from men with prostate cancer, and actually giving it to the patient to allow them to do that. So handing some of that power over to the patient. For patients, it can be very confusing. You know, their GP tells them they've got prostate cancer, and really it depends who they go and see first about what advice they have, what's best. So enabling through, for example, patient advocacy and consumer organisations to allow them to have that knowledge that there may be more than one treatment option, and working out what's best for them, and then measuring as they go along, looking at their outcomes and changing things if needed. If their prostate cancer progresses, then obviously progressing to more active treatment or more interventional treatment. But knowledge is power, so we need to be able to get over to patients. And again, that's why I think it's so important to bring patients along this journey. And an individual patient, it will be difficult. You know, a 75-year-old chap just diagnosed with prostate cancer may have no idea what he can do, but there are good, powerful consumer organisations in this country as elsewhere who can help us do that. So I think we need to work with them. And I think any new technology we introduce, we need to run this value-based lens through it. So prostate cancer is another good example, with a very wide introduction of robotic surgery, which has certainly got its values. But have we ever really run the value-based healthcare lens over the use of robotic surgery? I don't know that we have. And it's the same in breast cancer in my area and a lot of the new oncoplastic surgery. We've never really measured the outcomes, the patient-reported outcomes of this increasing use of oncoplastic surgery. And without doing that, is it giving patients what they want? We don't know.
One of the things that I think, in my experience as a clinician, has really had a negative impact on patient experience of their journey, even if they got really, you know, fantastic care in all the elements of their journey. When you have cancers where you really need multidisciplinary approaches to the cancer, the fragmentation of care that can happen when people are getting treatment in multiple different places, I think is really, really challenging. I like the idea of the bundling, because I think that helps address that by forcing people to come together to think about the patient journey. What are some other ways we can try to help patients in terms of their experience with this fragmentation, to kind of reduce the negative impact of it?
Yes, I think the idea of care navigators is a very interesting one, and that's actually a project that All Can Australia are undertaking at the moment, to look at what a care navigator for cancer might look like, and how that might be able to be funded both in the public sector as well as privately. And I think that's not a person that's not a cancer nurse specialist. They're obviously very, very useful in helping our patients, but it's somebody who helps patients navigate through the different geographical distribution of their care, as you say, the different clinics they may be going to, the different potential treatments that they may have or may not have. So the idea of care navigators is one that's, in Canada, I know they've been extensively used, and they've also been shown to reduce costs to an extent of cancer care. And I think it's one that would be wise for us to think about exploring here. We've done a lot of work in other areas. Things such as optimal care pathways are obviously a fantastic resource for being able to know what care pathways a patient should go through and should have available to them. But although we have the optimal care pathways, we haven't done a lot of work in how we're utilising those and how we're holding health systems to account to ensure that all of that is available to patients. So that's some more work to do into the future as well.
Kate White has a good question that most of the examples and your research initiative is focused on solid tumors. And has there been any focus on hematologic malignancy, or how should we include hematologic malignancy in this concept of value-based care?
It's lovely to hear from Kate. I've known Kate for a long time. Hi, Kate. There is in Europe quite a bit of work in hematological malignancies. In All Can Europe has quite a big input from some of the hematological malignancy groups, but I don't think there has been here. Saying that, however, I know that David Joski here in WA is quite interested in this concept, but I think it's an area that would be great and right to do, Kate. We just haven't done it yet in cancer. Not in Australia, I don't think.
You talked about the navigation and how navigation can save money. One of the challenges always is when you save money somewhere, but when you have to invest, but the cost savings aren't gained by the people who did the investment. Again, when you have this fragmentation of care, and so it becomes challenging to spend money, to save money, when the people who spend the money are different than the people that save. So what are your thoughts about overcoming that in terms of improving the value of the care we deliver?
It is, you're right, and this does cost a bit of money to set up these kind of systems. You know, it does take effort to put into it. It takes effort to put into not just IT, but resources and people collecting this, and then how the IT systems to feed the data back. But ultimately, I guess we do need to look at how it can save money by getting rid of care that is low value. I think we have to look at the bigger picture, and I think for that we really need the investment from our state ministries of health, and indeed from the federal ministry, from federal health as well, to understand how it's not just looking at one little bit of the journey, it's looking at things overall. And as I say, if we can also put this lens whenever we have new treatments coming in that may look very promising but don't always offer high value care. Sometimes, however, they'll offer much higher value care. So a good example may be around precision medicine and cancer, and looking at some of the genomic screening, so we allow patients to not have treatments that are not going to be very useful for them. So putting the lens on it over new treatments, I think, is a good way of ensuring that we get the best value.
Martin has a comment on bundling. Martin, do you want to unmute yourself?
Yeah, sure, I can. I don't want to interfere with the discussion between the two of you. Thank you very much for a fantastic presentation and discussion. I was just wondering about the bundling, the concept of bundling, which I very much like. But it's also very hard to achieve if you consider different funding streams. So we've got the pharmaceutical payment for the PBS, MBS funding, state funding. We've got primary care, hospital care. If you read about bundled payment, that's probably very hard to achieve that in the way Michael Porter has described it.
So I guess, Martin, we tried to, at the moment we're just trying it in a very specific area of early breast cancer. And in fact, we're excluding the things that were the most difficult, such as reconstruction surgery. It was just too hard to do. So I guess it's going to be little wins, isn't it? So what we're hoping to be able to do is having any patient with early breast cancer, so non-metastatic breast cancer, who requires, and it could be in different ways, in different models, so that they'll need surgery, systemic adjuvant treatments, radiotherapy, physiotherapy, perhaps dietetics, psychological support, counselling, navigation of care. We're trying to put all of that together into a bundle. But you're quite right, there are some things that are going to be very hard to do. I think what's important for the patient, though, is when they come into this journey at the beginning, they get terrible bill shock in this country when they realise that they suddenly have to pay for their physiotherapist who comes and sees them in hospital, or they have to pay for the pathology report that was sent off. They never thought about that, or their anaesthetist is an extra charge, etc., etc. If we can try and cover all of those and put it into a known payment right up front, it appears that most patients are pretty happy that they know what that's going to be. But they need to also understand there may be some things outside that. So for in our example of breast cancer, it may be that the reconstruction is completely outside that. I think small steps and achievable things.
So there was one question about the video that you showed, if there was a way to access the video. It's
on the Queensland Health website, so it's North Metro Queensland, but I can send that to you guys so you can put it on your website as well.
Perfect.
Great little video, I think.
Jasper DeBoer has a question here. Cancer researchers often focus on developing novel treatments or combining therapies in new ways, all with the goal of lengthening survival for patients. But some cancer research has a different goal: to reduce the amount and intensity of treatment patients receive while maintaining equally good cancer outcomes. Would your framework help with treatment de-escalation while still offering high quality care?
Oh, I hope so. Yes, I'm also passionate about de-escalation and doing a lot of work, for example, in the screening area and other areas around de-escalation of care. I think absolutely it lends itself to that. And the idea is if a patient gets for them a better outcome having less toxic treatment, then that's surely got to be a win-win for all of us.
Amen to that. Well, if there are no other questions, Christobel, I thought this was a fantastic presentation. The work that you're doing is really world leading and incredibly ambitious, really ambitious. So I want to congratulate you for that. And, you know, it would be great to continue to hear about what you're doing and to be involved in any way possible.
Okay, thanks very much, everybody. Goodbye.
All right. Thank you. Bye now.